I am from Giridhara Eye Institute, Kochi. I'll just start with the introduction, indications, planning of secondary IOLs. So, secondary intraocular lens implantation, indications, planning. I'll be also talking about AC IOLs. So, what is secondary IOL implantation? Implantation of an intraocular lens following an initial surgery that resulted in aphakia or a deficient intraocular lens. What can be the indications of secondary IOL? IOL exchange, as in incorrect IOL power, IOL subluxation, opacification of IOL, photopsias, dissatisfied patient with multifocal IOLs, IOL-induced inflammatory response and cystoid macular edema, IOL-induced endothelial decondensation, IOL removal, and later secondary implantation in chronic endophthalmitis. After congenital cataract surgery in children less than 1 year, after complicated cataract surgeries, the most common, trauma, uveitis, and after refractive surprise. Patient selection is one of the main things in secondary IOL. History, very important, because you have to sit with the patient and take a detailed history as on the timing of the previous surgery, the type of surgery, the trauma in detail, what kind of trauma it was, like what investigations is already done. If you have an EMR access to the already, or the case record access to the already done surgery, it is well and good. Refraction definitely needed, because you need to know how much vision the patient can get after the secondary IOL implantation. So a detailed anterior segment examination, including the conjunctival status, including the presence of glaucoma drainage devices, because when we are planning the surgery, there are many options of a secondary IOL. So which option to choose depends on the examination of the patient. Cornea, clarity, edema have to be noted. Pachymetry, yes, should be done. Specular, definitely, if to assess the endothelial cell count, especially when you are doing a AC IOL. And yes, chamber depth, vitreous prolapse in AC, you have to note. Even a white to white diameter also can be done. Iris and the capsule status. See the patient undilated before dilating the patient, because if you're planning an iris claw lens, you need to know the pattern of the iris, how the pupil is before, and whether there are thin areas in the iris before doing that. Always see for the incisions in the primary surgery, like whether an SICS was done, whether any retina procedure was done, whether there is a buckle, you have to see before. That means examination is really important before you proceed with or you plan the secondary IOL implantation. If an IOL is present, the degree of subluxation and the type of IOL, because when you're planning a secondary IOL, can the primary IOL be reused? That should be kept in mind. So the type of IOL should always be looked forward. The timing of the prior surgery, whether the SICS wound would have healed 5-6 years back, the SICS was done, whether we can open the same wound or should we make another wound, all depends on your examination or the anterior segment examination of the patient. Posterior segment examination is valuable in case that some conditions limit post-operative results. That means we'll have to definitely keep in mind whether the patient will improve after doing a secondary surgery, whether we are going to incite inflammation, whether the retina is good or bad, because after doing the surgery, the patient should get some vision. If the patient is not going to get vision, should we definitely take the patient for the surgery? That should be kept in mind. And one advice is always, if there is a subluxated cataract or if there is a subluxated lens, make the patient lie down and see how the lens dangles, like if it is in the mid-vitreous, because when we sit, if there is a superior attachment of the lens, we cannot see that. But when the patient lies down for the surgery, then you'll have to definitely have a retina backup. So the retina backup, we should already tell to the retina persons, otherwise they won't come for the retina thing. So keep in mind, make the patient lie down and see the patient, see where the lens is. So that is regarding the patient selection and the criteria before considering which type of lens or which type of secondary IOL that should be, that the patient should undergo. So the options are a single piece or a 3-piece foldable IOL in the back, or a 3-piece implantation in the sulcus. AC IOL, iris fixated, can be anterior or retropupillary, and scleral fixated lenses in many forms. Determination of anatomic location of the secondary IOL. Choosing the best location and technique for secondary IOL implantation can be a difficult one, and there are no clear guidelines that this lens should be used for this patient. It is our criteria, like which type of surgery or which type of implantation we are comfortable with, definitely has a role. Recommendations in ruling out certain anatomic locations for IOL fixations. That is, if the endothelium is poor, like poor corneal endothelial status, abnormal iris angle anomaly, then AC IOL, no. Lack of adequate iris support, you cannot put in an iris claw lens. Lack of posterior capsular support or a fibrosed anterior or posterior capsule would rule out in the bag IOL placement. Sulcus IOL placement can be done if the anterior capsular support is good. Scleral abnormalities always should be looked forward before doing an SF IOL, like in Marfan's, when there is scleral thinning, chronic uveitis, etc. should be ruled out before doing scleral fixation techniques. All these things should be kept in mind before doing the surgery. Simple algorithm. A patient planned for surgery, if the anterior capsule is intact and if the bag is quite good, go in for in the bag placement of the IOL. If it is not there, if it should be placed in the sulcus, go in for a 3-piece IOL. If intact anterior capsule is not there, and if there is a sufficient iris tissue, I have already told that you have to see the patient undilated. So go in for an iris fixated lens if there is sufficient iris tissue. And if it is not there, see whether a pupilloplasty can be done in case of trauma and all. If definitely iris is quite good, the pupil is quite round and all, you can try in an iris claw, but better go in for a SF IOL. You can put the secondary IOL in the capsular bag in the early postoperative period before the formation of anterior and posterior capsular adhesions. Ideally, it should be performed 4 to 6 weeks of the within 4 to 6 weeks of the initial cataract surgery. Although in the bag IOL exchange months to years have been reported, but it's quite cumbersome. A few words about anterior chamber intraocular lens. We are all putting iris, claw, bar, SF IOL in many forms, but there are people putting anterior chamber intraocular lens even now. Baron was the first to implant an anterior chamber IOL in 1952. Closed loop AC IOLs in 1970s. Open loop in 1980s, 1990s, all were open loop designs. Even now, we have very modified versions of the open loop AC IOLs. Angle to angle measurement measured by UBM or OCT, if you are planning a secondary IOL, can be done, but on the table, you can do a white to white distance measurement and intraoperatively with calipers, and 1 millimeter is added to the size of IOL before putting in an AC IOL. So when you put in an AC IOL, the size matters. So that's why they have already told white to white measurement is needed. When you put in if it is not available, only one size of ACIOL is available. When you put in an IOL, see whether it is very tight, whether the pupil is stretching too much. That means it is going to create trauma to the angle. There can be, because once you put in the lens, the patient develops many complications. The patient will tell, no, before surgery it was very good. Only thing I couldn't see. After surgery, every day I'm having pain. It will be really difficult for the patient and the surgeon, because every day the patient will be coming. Long-term steroids may be needed, and also keep in mind that adequate sized ACOL, if it is available in a secondary IOL procedure, that will be ideal. Just going into a small video, this video courtesy Dr. Sai Kumar. So the scleral incision SICS wound is there, pupil is round, myosed, PI is made, ACIOL is visco is put, ACIOL is just inserted, and then you have to gently nudge the ACIOL into the and the ACIOL actually has to crawl in the angle, and it has to nicely sit in the angle. So see, the PI is always made prior to putting in the ACIOL, because after that it's not possible. And suture the wound, if it is not very tight, that will be good. Thank you.